Good morning. I'm Priya Palta, and I am the chair of the planning committee of this year's AHA Epidemiology and Prevention, Lifestyle, and Cardiometabolic Health scientific sessions. I'm joined here by two of our three keynote speakers. Dr. Adam Rodman from the Harvard Medical School joined us this morning for his keynote talk, but will be unable to join for this interview today. But today we have Dr. Dina Katabi and Dr. Tina Ann Thompson. So maybe I'll let you both introduce yourselves.
Hi, I'm Dina Katabi. I'm the Swan and Nicole Pham Professor at MIT.
And I'm Tina Ann Thompson. I'm a family physician and the Senior Vice President for the Primary Care Service Line at Emory and the Division Chief for Family Medicine in the School of Medicine.
So our keynote speakers kicked us off this morning for the theme of our conference, which was A New Era, AI in Cardiovascular Health Research and Practice. And so the goal of this theme was to really sort of get our audience thinking a little bit more about how we use AI in research and how it's changing the use of how we deliver care to our patients. And so Dr. Rodman gave the first talk and gave a very compelling talk, really talking a little bit about the history of artificial intelligence, as well as sort of how much of an evolving tool it is, things that we should be maybe cautious about. And so I wanted to ask each of you to maybe go through sort of what are the key highlights and take-home messages that you want to share with the audience about the talk that you gave this morning. So maybe I'll start with you, Dr. Katabi.
Today, one of the limiting factors in how we treat the patient is the ability to know how the patient is doing between visits.
Right.
And relying on patient measuring themselves or even the wearables prevent us from attending to the people who are most in need, the ones that have compliance issues and stuff like this. So one of the things that I talked about is that how AI provides ambient health monitoring, that from the wireless signal that bounce off our bodies, an AI neural network can analyze that and get our physiological signals, our vitals, our sleep, our movement, and all of that stuff with zero burden to the patient, no compliance. No compliance issues, right?
Right.
And so just to touch on your points about what happens in between visits is after we, together with the patient with shared decision-making, make the plan of care and lifestyle and medications and all of the things that we've said, we cross our fingers in reality and hope that what we said in those 15 minutes will continue through until the next time we see the patient for 15 minutes. And the reality is that much of it does not happen. And then the cardiovascular risk continues to increase between visits. So we are starting to think about how we use AI agents to be able to outreach to patients to find out if there are any barriers to them being able to complete the things that we discussed in their visit. The other thing that we're looking at is how we decrease the burden for our physicians and our nurses who interact with patients between visits, specifically with the patient portal. And we talk a lot about how we may be able to pull in information from the chart and use AI to help the clinician to be able to draft the message that will reach the patient in between visits so that when they interact with us, we are able to respond to them without an additional burden.
Yeah, I guess with the two things that we talked about complement each other very much. You guys are trying to reach out to patients through AI agents to talk to them and ask how they are doing. And we are trying to reach out even without completely passively, continuously monitoring them. And I can see these two things working together very well. When somebody does not answer, whether the nurse or the AI agent, having the information still being collected because it's collected passively in their home without burden, and also taking that information and using it with your AI agent to fit it within the medical record and have more holistic view of their health.
Absolutely. And as Emory traverses this value-based care space, right, some of the use cases that I could see would be after a patient is discharged from the hospital, to be able to have a way to not attach them to a wearable, but to be able to figure out if they're at risk of falling or at risk of any of the other adverse events, then we could have a human to call the patient and check on the patient. So huge use case for preventable ER and readmission visits. So I was very excited to listen to your talk. And the other thing is, as we think about just rising risk, folks who have high blood pressure and have diabetes, how might we be able to use this tool to maybe not long term, but to figure out which ones of these patients would be at risk for advanced cardiovascular disease?
Yeah, that I'm very passionate about like basically how we can reduce hospitalization and ER visits, particularly.
Thank you.
I mean, I think we really have like we have the ability. Is that we just need like more activities in that domain. And many of these cases, particularly like in heart failure, we know that if we discovered it early on, just a diuretic can solve the problem.
Exactly. If you can assess the breathing, if you can assess how much less the patient is moving, how much more interventions could we do to help prevent the patient? Because no one really wants to go to, maybe not no one, most people don't really want to go to the hospital. It's expensive and it's not the safest place to be. So the best thing that we can do is to keep the patient as healthy as they can in the situation that they're in. So would love to think about how we might start to scale some of these opportunities across our other health systems and with our insurers and our payers.
You guys are doing a lot in the value-based system. It's very interesting to hear you.
Absolutely.
Well, maybe I can ask a follow-up question because I had a couple questions during the session, but there was a long line at the microphone, so I couldn't get it in. So you mentioned reducing staff burden, participant burden. How much time saving do you actually think it is for you as a provider, for the other healthcare providers in terms of having that AI agent?
So having the AI agent to outreach to patients to collect information on their blood pressure is definitely human hours saving.
Yeah.
There's no question that we saved about 2,000 hours in outreaching to patients. There's no question about that. The way that we use AI in our day-to-day work with scribes and assisted response technology so that we are getting a draft of a response to a portal message. We're getting a draft of note with the history of present illness, the assessment and the plan, and even the physical if we say it out loud. That does not actually save that much time.
Okay.
You're talking about single digits of minutes of saving of time, but there is a perception that the burden is decreased.
Yeah.
And so it is for many people easier to edit than to write. And so we are seeing that folks are feeling less burdened when they use our AI scribe technology that we've offered to them.
There was one thought that I had as you were talking about the AI agent and them calling the patients. I was curious if you ran into situations where the patient was asking the AI agent more like health-related questions because it was their chance to talk to somebody.
So we've heard those stories about the agent as serving as a companion per se for patients who are lonely. I think it's important that we use the information that we gather to help to do interventions. Yeah. So if we're hearing, thank you for calling me, no one else has called me today, it's important that we use that data to figure out that loneliness. And that loneliness we know is an issue as it relates to health outcomes. And so it's important that we collect it. Now, when we go down hallucinations of asking about how the day is and how well we ride horses and things like that, it's also just as important that we have guardrails set up that the AI agent says, this is outside of my scope. I'd like to bring us back to the questions that I have for you. And if you do need to reach out to someone, please reach out to the nurse at your doctor's office.
Dr. Katabi, I had a couple questions during your talk as well. I was really struck by really the high predictive accuracy for these conditions. Were there any that were maybe, I couldn't tell if there were any that were lower than you expected? Is there a reason why maybe they didn't have as high of a predictive accuracy for some conditions versus others? And what would you hypothesize the reason being?
Again, I mean, lower than expected, I would say no, because the expectation
I mean,
was
it
that
was-
there is no information
Right. It was
whatsoever.
90%, yeah.
Yeah, but being able to, like, there were things that were very surprising. I mean, I was surprised, like, as I mentioned in the talk, like some of the early conditions that we discovered, like that we can, from respiratory signal, detect Parkinson, for
Yeah.
example. That was the earliest result we had. And then we moved to other diseases. We showed that we can detect CHF, COPD, Alzheimer, and even drugs like antidepressant and so on. Now, of course, there are certain things that we tested and the accuracy was low.
Right.
So we, for the existing model, they cannot perform very well on those tests. But that was not the surprising part. I think the
Yeah.
surprising part was the opposite, that this was able to
do it.
perform on a very large number of tests,
Yeah.
and both for detecting the disease and the exposure to drugs.
Yeah. It was fascinating. I mean, to be able to put a monitor into your home and be able to detect all of these physiological signals is amazing. So really exciting.
Yeah, I think you guys are in a very exciting domain. Like it's I do think that AI for health is going to do much more than in, like, I can't think of any other domain where the opportunity is as high.
This is one of those times where healthcare is not pulling up the rear, right? I
Yeah.
feel like in so many other technology and advances, it seems like we still get faxes on paper. And I talk to physicians that they're like, we still have faxes, but we're also using AI. I mean, it's just fascinating that this is an area that we have said in medicine, our patients can get some benefit. Our clinicians can get some benefit. And we are not the laggards like sometimes we can be. I love my profession.
Do you have any sort of last minute notes, take home messages that you want to share with the audience? Maybe about what you learned about each other's work and talk.
So I'll go first. I ended the session as a user. I am the one who gets the information from the agents. I use it in my day-to-day practice, and it is really an exciting time to be one of the people who can see the benefits of this new, what I think is new, but we realized in our first speaker, not quite so new, this new area of technology. And it's important that we continue to collaborate. So I love meetings like this. We have our technical folks, we have our PhD researchers, we have our epidemiologists. And when we start to learn from each other about different use cases, about ways that we can collaborate, I really think this is one of those times that healthcare can be at the pinnacle for this is how collaboration really should be. And these are the heights that we can get to when we continue to work together.
I mean, to me, it's of course, it was very exciting. I mean, it's like one of these sessions like that I was learning from the other speakers and finding all the connections. So it was very exciting and interesting. And the opportunities are unlimited.
Yes.
One of the things, like not being like an outsider to the healthcare domain, there is the issue of incentives and whether like how the structure here in the U.S. and that prevents certain things that would yield the better outcome for the patient. So what I really hope is that at least with now you're talking about value-based care, that at least we can keep advancing these mechanisms and use them for the best of the patients and the clinician. That would be very interesting and very important to ensure that the regulatory system do their job in protecting the patient, but also allowing them the opportunity to have better care.
Well, I want to thank you both for taking the time to talk to us about your research and your work. I know that it stimulated for me a lot of thoughts and questions. And as I think about how can I use these ambient monitoring devices potentially in our cohort studies where we have, participants that we've followed for 30 years and we want to capture, we're capturing all this information. How can we incorporate some of these tools into our research and how can we incorporate these tools into our clinical practice? So I just want to thank you both for very stimulating discussions and talks. So thank you.
Thank you.
Thank you.